We're going to settle in, but this is the New York State is addressing the homeless mental health and overdose crisis workshop. You have the right one? Great. This is the Astor Ballroom. So I guess I'll start by introducing myself. I'm Blanca Ramirez, and I'll be moderating this panel. I am the president and CEO of Comunilife. I'm only 3 months in, so no. Thank you. No need for a clap, but I appreciate it. But I'm excited about this conversation. I have some really great panelists here. Each of the commissioners have taken the time out to come join us on having this discussion about where we are in the state around homelessness, mental health, and substance abuse. So I'm excited to get started. So why don't we get started? I'll have each of the commissioners introduce themselves, and then we can get started. Commissioner Cunningham.
Great. Thank you. So I'm Chinazo Cunningham, a commissioner for Oasis, and very happy to be here today on this panel with my colleagues. We are a small but mighty agency. So, I also just have to say, from a personal standpoint, so I'm a physician for 30 years, worked in the Bronx for over 20 years, and really worked to provide better access to care for people who use drugs, and worked with people who are unhoused, people with HIV and drug use. And so I have actually worked in SRO hotels, gone door to door, done outreach for over a decade, so I definitely understand how important housing is for the population that we serve, even though our portfolio is really quite small compared to the other agencies up here. So we all know we're in the worst overdose crisis, on record, so I appreciate that this is also part of the discussion here. And at Oasis, we oversee 1,700 programs. We touch over 700,000 people. We have state-run 12 addiction treatment centers. And so we certify and we regulate and support all the addiction programs in New York State. Really, when given where we are right now with this overdose epidemic, we're really focusing on harm reduction, a data-driven approach, and using an equity lens in everything we do. So harm reduction is a key principle that really, permeates all parts of our system, and it's about meeting people where they are, providing life-saving resources, reducing barriers, and really focusing on reducing harms associated with substance use. And I think this is really an important part of housing too, not expecting people to be perfect or abstinent, because that's really hard to do, but still keeping the doors open and providing services. From an evidence-based standpoint and a data-driven standpoint, really focusing on the data. Obviously, we know fentanyl is killing people. We know stimulant overdose deaths are also on the increase, and we're really focusing on, the different patterns that are happening across the state to make sure that we're following the data and the science in terms of our investments, our resources, and our tools that are available. And then just in terms of an equity lens, and I know certainly for housing, we know housing policies, we know addiction policies, substance use policies have been racist in this country. We need to say that and recognize that, and we need to make sure that we don't make the same mistakes going forward. And so really using an equity lens in everything that we do, top to bottom, in terms of funding, in terms of the data that we collect, the data that we analyze, in terms of who's on our advisory boards. I mean, the whole thing, really using an equity lens in everything that we do. So I'm really just going to stop there, and then except for one last thing, which is even though we're at some of the worst points ever in terms of overdose deaths, this does create for new opportunity and innovation and new investment. And so I think it's a double-edged sword where we actually have real opportunity to do things differently than before. And I think there's a willingness for people to think differently about addiction. And we have some major changes in federal regulations as well, specifically around the methadone treatment. So we are really trying to leverage those changes and leverage this changing paradigm and people's willingness to think differently as we move forward. So I think for us that is part of the excitement about where we are and where we're going, and then also that we have a governor who is very, very supportive of the work that we're doing, and where harm reduction fits in that, and really allows us to lead in a way that we should be moving forward. So that's our big picture vision.
Thank you. Commissioner Guinn?
Hey, good afternoon, everyone. My name is Barbara Guinn. I am the Commissioner of the State Office of Temporary and Disability Assistance. For those of you who don't know, our agency is responsible for oversight and direction to the 58 social services districts with respect to many programs, including the provision of public benefits, such as public assistance, food assistance, energy assistance. We also oversee shelter services throughout the state, have responsibility for the Child Support Services Program, Refugee Services Program, and of course, we also fund many nonprofit providers to provide various services associated with those program areas. We also administer the Homeless Housing and Assistance Program, which is the $128 million capital appropriation to support the development of supportive housing. It's a really important program for us because we know that supportive housing is one of the most essential elements for helping us to reduce homelessness and to improve the lives of individuals, particularly those who have been chronically homeless in our state. A few HHAP-related updates. So the program itself is 41 years old. It's supported over 28,000 units of supported housing throughout the state. This past year, we were fortunate to award 20 new projects supporting 735 units and also open 19 different diverse projects throughout the state. Pleased in April to have worked with HCR to be part of moving forward with an award to support a hotel conversion in Kingston, New York, which is in Ulster County. We definitely also appreciate that opportunity and do see it as one of the many avenues for us to be able to create more supportive housing and affordable housing throughout the state. And that program will also benefit from ESHI funding. With HHAP overall and supportive housing overall, we know there are a lot of places where we all need to be very mindful and make sure that we're addressing some needs with respect to supportive housing. That, of course, includes the increase in development costs that folks have been experiencing. That OTDA was fortunate enough to help an additional, I think it was 11 projects we were able to provide additional funding to them post-closing on the initial award because of those increased costs, because we know that we just can't let these units be lost to the state. We're also very mindful of our aging portfolio and we know that we as a state need to address the needs of the aging portfolio within HHAP and other areas of supportive housing to keep units online. I will, with that, acknowledge the New York State Supportive Housing Program, NYSHIP, and its the disparity in the funding available for that program as compared to ESHI and some other programs that are available to support supportive housing throughout our state. We've also been working, or I should say our HHAP staff have been working really hard also recently over the past 18 months to 2 years to bring in more nonprofits and developers in areas outside of New York City. They've been holding roundtables to bring in multiple players from within the community to help people understand the resources that are available, the steps that are needed in order to create more supportive housing. And so those are certainly have been successful and have already started to pay off in terms of bringing new players into the game. Also want to acknowledge we have the Solutions to End Homelessness program. That procurement awards will be going out this summer, and we look forward to moving forward with another round of that important homeless services program. Other priorities for OTDA, obviously homelessness is a big issue for us. Homelessness is up throughout the state, in particular in New York City. It's in many parts of the state is really a direct reflection of the housing supply and the need for more affordable housing. And then obviously within New York City, the recent large numbers of new arrivals to the state has certainly placed a lot of pressure on that system. And so we've been working very closely with New York City, Homeless Services and others in order to help them manage that, which is quite the task, and I must say it's been a journey, and they have worked really hard to be welcoming and to try to meet the need, and so we're really appreciative of them for those efforts. Other agency priorities is just in general benefits access, making our programs more accessible to all individuals throughout the state through improved efforts by us to both provide additional outreach, but also to streamline our programs and to simplify our programs. As part of this effort, we're really looking to make sure that our program models are much more evidence-based, and to basing our rules and policies on evidence, not just on folklore or some random thing that happened 10 or 15 years ago that we continue to do. And so certainly working in conjunction with our partners here to learn more about that evidence and how we can improve our policies so that we're better serving individuals who often are marginalized and unable to benefit from our services. And then lastly, one happy thing we have going on this summer is we are starting a new program, which is the summer EBT program, which is a food benefit that will be made available to over 2 million children throughout the state this summer, and then permanent going forward, we hope. Provides about $120 for the summer for each child who is eligible for free and reduced price school meals so that they continue to have access to healthy food throughout the summer. It's not always easy for people to know whether or not their child is eligible, but please go to our website. We've tried to make it very clear. So we would appreciate you helping to get the word out and helping educate folks about that important benefit. Thank you. We're happy to be here today.
Great, thank you. Commissioner Sullivan?
Hi, good afternoon, everyone. It's a real pleasure to be here with all of you and with my fellow commissioners, and we work very closely together on all the initiatives I'm going to be talking about. And I would also just like to thank all of you for the incredible hard work that you do each and every day. There's nothing as important as housing for recovery, and you are just so critical for the clients that we serve, so thank you. Over the past 2 years, we've had a pretty heavy increase in the dollars that have come into OMH and into mental health. And thanks to a governor who I think sees the whole continuum of care, and that's why I just want to talk about that for a minute. The whole continuum of services is critical, all the way from prevention through the infrastructure that we have in mental health for clinic services and episodic treatment and cancer, crisis treatment, all the way to the most intensive services and a huge emphasis on housing. So it's that continuum which is being built over the past 2 years, and it's really quite impressive. For example, in the first section of that, which is prevention, we now have over 1,400 school-based clinics across the state. That means that in a school, there's a clinic that can work with that youth. And what we're going to be expanding this year is youth to youth, what they call teen mental health first aid, where youth help each other. It was one of the things that came up when we did summits across the state and asked youth, what do you want? And they said, you know what we'd like to do? We'd like to be able to know how to help our friends when they come to us with their problems. So we're going to be expanding that across the state. So that's an example of the prevention. And then there's this incredible increase in the basic infrastructure. Over 42 new ACT teams, which will open up across the state. And in this year's budget, another 15 forensic ACT teams. So building the ACT team structure so that we don't have the kinds of waiting lists that we've had for years. Also Youth ACT. They'll be by the end of the time all the funding comes through, we'll probably have over 20 Youth ACT teams across the state. So that's an incredible increase in the infrastructure, an increase in ACT teams, an increase in CPEPs, an increase in our basic clinic work. That investment enables all New Yorkers to get access to care. And then you talk about the more intensive services that are needed. And here I think we're going to be starting something which I hope will be really helpful to you in addition to the housing, which is something called the critical time intervention teams, which are going to be linked to transitional residences. Those critical time intervention teams are well-staffed. They can follow somebody for up to a year or more, and they can help them through their transitions from hospital to housing, to success in the community, from emergency room to housing, to success in the community. That bridging hasn't been there in the intensive way that some individuals need. And I think that's a huge addition. Many of you are involved in providing those services, and we're going to really watch and see if this works. This is something which we would like to continue to expand so that those individuals who need the most intensive work get it. The experience of our SOS teams, our Safe Option Support teams in the subways, which I think are a model in a way for this, although these will be more individuals coming out of hospitals, has worked extremely well. We're using a housing first model where we have now been able to permanently house 500 individuals who were on the streets, often in the subways, for over 5 to 10 to 20 years. We have anecdotes of individuals, one individual who spent 20 years in the subways who walked into his first housing first apartment a few months ago. So that's the kind of work that these teams can do in conjunction with housing. And so I think that's one of the prime things that which are new that we're doing, in addition to all the great work we continue to do. And then a huge piece of those dollars that came in were for housing. So $890 million in capital for housing across the state, 3,500 units for mental health. I mean, that's an incredible, incredible investment. And I think most of you were involved in applying for some of that. We have gotten all the RFPs out. In fact, I think of the 3,500, 3,450 have been RFP'd, and about close to 2,800 have been awarded already. So we know those conditional awards, but awarded already out there. So that was a tremendous, I can't believe that my staff were able to do this, but we pushed the money out. So we have all these dollars, which were talked about from last year, are out there. And then in this year's budget, there's been an increased emphasis on forensic. So we're having our Forensic Act teams. We've got another 100 units of housing for individuals leaving jails and prisons or that are at risk for jails or prisons, and we're getting court navigators. And there's going to be an increase in the mental health courts across the state. Mm-hmm. So it's constantly building and finding the gaps and putting those gaps in place to strengthen the entire system and the continuum of care. But to really make it happen, it's got to be all of you and us and the workforce out there. And I know that there's been investments in loan forgiveness. Just to give you one little bit of a bright light, we put $9 million out there for loan forgiveness for psychiatrists and nurse practitioners about 2 years ago. So that money's been out there for a while. 400 individuals have taken that loan forgiveness and have entered the system for up to 3 years. So loan forgiveness works. It helps. The second amount of loan forgiveness that's coming out is going to be for social workers and psychologists and mental health counselors. And that's coming out very soon. And that loan forgiveness will be there, and we are thinking that'll be about 500 or 600 individuals will have access to that. And then a third amount of loan forgiveness in this year's budget, again for everybody here, nurse practitioners, psychologists, social workers, mental health counselors, for people working closely with kids. So it's another bucket. So I think this is something, and you will also, on the 1115 waiver, keep looking at that 1115 waiver. There's loan forgiveness in the 1115 waiver as well. So I think that's one of the big things that we're pushing out there and has had success in pulling people into our system in terms of increasing the workforce. So I'll stop there, but just to also thank you all. I know when we pushed out a lot of these RFPs, everybody's saying, can you, it's like, it's a flood of applications and things coming out. You've been incredibly responsive. We've gotten some wonderful RFPs, many of the awards, and I just can't wait to see the fruits of all this, because I think in a year or two, with the kinds of investments that we've made, I think we'll be able to see some real transformation in the system. So again, thank you all.
Thank you. Wow.
Hi, I'm RuthAnne Visnauskas. I'm the HCR Commissioner, and delighted to be with you here today. Blanca, congratulations on your new role. It's great to have you here at the helm. And I think last year when we were here, you might have been acting Commissioner Guinn, maybe. So congratulations on steadying the helm. Yes, over there at OTDA. But really, really an incredible, I think, reflection on the governor's commitment to mental health and to housing as a part of that, to sort of hear all of the money and all of the funding programs, and also just sort of a powerhouse group of ladies to my right here thinking about these issues and really trying to move the dial in New York State. So thank you for having me here today. As folks know, we at HCR are in the midst of our 5-year, 100,000 unit housing plan. We just finished our second year, so we are a little north of 40,000 units, right on track with where we should be. And while, we get to claim that as our sort of agency victory, we don't do any of that without all of you. So thank you, everyone, for the incredible commitment to not only responding to all our RFPs for dollars, but also all the deals that have to get closed, then they have to get built, then they have to get rented up and stabilized, and those loans converted, and it's really a tremendous effort. And so we feel very proud to be sort of, on time and on budget, as it were, in the process. We do an enormous amount of supportive housing, especially in New York City, but really across the state, and we do it very much in conjunction with OMH and OTDA and OASIS and the Department of Health, and we are really sort of proud of that. I think that we have worked really hard, as the industry has, to make sure that we are integrating supportive housing everywhere we can. The need is in every corner of the state, and so as we are building our housing, we want that need to be getting addressed and reflected as such. We are also very focused on preservation of supportive housing, as folks certainly have said to me, and I try to echo back wherever I am. We can't just sort of build new housing. We have to make sure that the housing that we have built stays in place, and it can still serve the populations it was intended to serve. And I think I said this last year when I was up here too, that we would certainly want people to please come talk to us about preservation of existing supportive housing. We have funding for that. We know that those buildings have capital needs. We know that expenses have gone up dramatically, whether it's insurance or utilities, and there's a lot of pressure on the operating expenses of the buildings, and most of them have pretty fixed rental incomes. So we want to work with you on that as it relates to sort of preserving housing across the board. I would also sort of just sort of a shout out and appreciation of support for federal resources. We do as much housing as we can in the state of New York, utilizing the 9% tax credit and tax-exempt bonds and 4% tax credits. And I sort of think of myself as the brick and mortar at the end of all the services here at the table. And we need those federal resources to do that. We were thought we were sort of close last year with the tax bill at the federal level to get a big expansion and our ability to issue tax-exempt bonds, which would have maybe not quite allowed us to double our production, but pretty close. And that is, frankly, one of the most sort of impactful things we feel at HCR that we can do to increase housing supply, especially supportive housing supply. We are just coming out, for folks that may or may not have tracked the budget and or legislative process, coming out of a budget season this year with an enormous number of policy changes and investments in housing supply across the state. The vacancy rate is at a level that it hasn't been in 50 years in New York City, and we really feel that one of the tools for that, not only in New York City but across the state, is making sure that supply continues. We need supply of all sources, but certainly for us parochial at HCR, we are really advocating at the federal level to increase resources so we can continue that production. For anyone who's applied for a 9% deal or a 4% deal for us, that we have 2, 3, 4 times the number of applications than we can fund in any given year, and that's really us being reliant on the federal government. The state has been incredibly supportive with capital resources, I think, up and down the table here, and certainly for us at HCR, we have capital to spend. So appreciate the advocacy from all of you, and just sort of want to put a plug in on that. Also, many folks will come often ask at these things when our next funding round is coming out, and we'll be putting out our next 9% round in the sort of late summer, early fall timeframe. We had been doing them twice a year, and we have gone back now to once a year RFP and award, and we will therefore sort of award more projects each time. So do look out for that. And with that, I'll just sort of close and say, we are very open at HCR to suggestions, to way to get more built, to more policy changes that we can make in the work that we do, and we mean that genuinely. So please, Shani does an incredible job advocating, and we are always open to to trying to bring in more populations into our buildings, to be doing more with our ground floors as it relates to healthcare services or fresh food, and to really making our buildings both for the tenants and also for the communities where they're built.
Thank you. You're not busy at all. But just to kind of pick up on something you said, I keep wanting to call you RuthAnne.
Please do. Please do.
So I'm going to go with RuthAnne then. Thank you. So you talk about the various initiatives. So one question, as you're being very creative in how to put out more supportive housing units in communities throughout the state, have you seen or how have you approached or how have you seen developers approach mixing various different populations in a building, from chronically homeless, various different barriers to housing, but as well as just community units in the buildings?
Yeah, look, I would say we're incredibly fortunate in New York City and in New York State that we have like a powerhouse development industry that not only produces at the level we produce, but is constantly pushing the envelope on populations, on services, on sort of, as I said, sort of community facilities or what's going in the ground floor. There are projects that I have been to in the last couple months that are youth aging out of foster care, formerly incarcerated individuals, formerly homeless young adults, formerly homeless families, individuals with mental health and substance abuse issues. I mean, it's just every issue that we need to be addressing, and oftentimes combined in the same building and pulling, as you all know far too well, from 3 or 4 different service contracts to sort of make that happen. And sometimes I feel like my kids could almost do the alphabet soup of programs that we all have here because we talk about them so much. But it's really, it's on the one hand, we should make it all simpler and easier. But on the other hand, it means that we are serving a really diverse group of needs in individual buildings across the state. And I think most people would like to say that's sort of what might have been happening organically anyway through big periods of the city's development. And now we are being more intentional in providing more services. And it's really great. It's a wonderful result to really see the integration of services. And we will, as creative as people can be and can get on that, we are sort of willing to meet them there on the funding side.
So, I mean, most of the service outside of New York City is around Ishai. So we're, in year 7 of a 15-year initiative around Ishai. So what's the next approach from the various different agencies providing services? How do you see meeting the continuous need, right? The needs are growing. The money is staying the same, with the continual commitment from the governor, which is great. But from each of your perspective, where do you see it going from here?
I'd be happy to address that first. I think just kind of building on what Commissioner Visnauskas said with respect to, we definitely are seeing more developers and nonprofits coming together and serving that mixed population, which makes a lot of sense. We would encourage folks to think about the service providers that are going to be part of that model to make sure you have appropriate services. And, because of the governor's commitment and funding a broad range of services in mental health and substance use and other avenues, there are services more likely to be available, but we would just encourage folks to continue to kind of bring the service providers in early as you're planning to make sure that the facility meets the needs of the different populations being served. And we certainly support and have seen more and would like to see more of the mixed approach with respect to not just the populations, but also supportive housing mixed with the affordable housing, I think is another really positive model, and bringing in community partners to really create, a mini community, right? Where people can feel safe and feel very welcome in their home. Being at the state level, I can say that this morning, just hearing from the tenant advocate, Ms. Taylor, from one of the Fortune Society supportive housing programs, and just hearing her and not just what she said, but the way she said it. And they celebrated my birthday. That never happened for me. They checked on me. And it just kind of, for an agency that is very much oversight, not direct service delivery in many ways, it's just kind of brought home, and it'll stick with me for a long time, the power of supportive housing. And as people are being able to build more and provide more services through Ishai, and other funding streams that, you really are creating communities. And, as everyone else has said, just thank you for everything that you're doing to support people throughout our state.
I think that the commitment, we have to sometimes keep in mind that the commitment to supportive housing in New York is beyond any place else in the country. I mean, the amount of supportive housing that we have for all disabilities, for anyone, is just phenomenal. And I think that while, we continue to struggle, we continue to need more, we continue to need higher rates and more dollars for services, the reality is that it's really an incredible service. And I think that, the ESHI has been very great for mental health. I think we're about 26 or 27% of the ESHI units. And also, it's a community, so you really want individuals with mental illness as much as possible to be living in a community of mixed individuals with mixed issues. That's what you want, ultimately. When we got the capital back for the 3,500 units, I think it gave us the flexibility to think of new models, and that's what I think is also important. So like the transitional housing with these CTI teams that we're putting up is something we hadn't done before. And we'll see if that works. We've got our fingers crossed that it works. It seems to be working with SOS, and we're hopefully that with the other teams it'll work. Also, we'll be expanding apartment-based treatments, which I think is something that's really been incredibly helpful in getting some of our clients really ready to be totally and completely, really independent in the community. So it gives us more flexibility. And then we heard from all of you that we needed some more CRSR. People have been saying this to us for years. It wasn't in some of the other capital plans, and we've got some of those in that 3,500 units, some CRSR. I never get my initials right, but that kind of housing. So it's given us the kind of flexibility, and I think that that's something that is important, and probably not just for individuals living with mental illness, but for other disabilities, that we continue to think about flexible approaches. And I think that the governor's investment in that has also enabled us to be able to do that. So I think we're on a good pathway for housing. I don't know that there's ever enough yet, but I really think it is a remarkable investment across the state for all disabilities.
No, that's true.
So I can just add, just in terms of ESHI for us at OASAS, so, we'll continue to grow. So we currently have 13 providers that have 24 ESHI programs, so it's about 250 units. And we have 7 additional projects that have committed awards, so we expect those to come online soon. And then by 2025, we expect approximately another 300 units, so that'll bring our total up to about 550 ESHI units. The other thing I actually didn't mention when I first talked to you, I think that's really important here for us at OASAS, is the role of recovery housing. So that's also new for us. It's sort of happening with various states now of sort of bringing recovery housing under the umbrella of OASAS. Right now, it's a little bit of the Wild West. We don't really know what's happening or how much there is, and there's no clear standards. So I think this is a really good opportunity for us to really have very clear standards, and for the public then to know what the recovery, housing options are, and again, just really thinking about the whole continuum of services, as Commissioner Sullivan said, all the way from prevention to recovery and housing being a key part of that.
So as a follow-up to that, as our industry changes, various different population services changes, what about housing first? I mean, even through years, we've talked about supportive housing and housing, the hardest to serve. Is that continue within the work? Are you still seeing that, very low barriers in housing individuals with high service needs in supportive housing? And how is that being approached from each of your agencies' perspective? Housing First as a model kind of started in New York and then fell, to be honest, at least for OMH, fell off a bit. So that was
Well, it happened. But I think where we're at now is that there's an increasing appreciation for the importance of individuals, especially individuals who've been homeless for a long time, to be able to access housing quickly and to get good housing kind of right away. And that's been our experience with these SOS teams. That's a housing first model.
Right.
And we have 700 units now across the state of housing first. And for SOS, we've been using the housing first model, and I think that's why we've been successful largely in getting those 500 individuals permanently housed. We're going to be increasing to another addition. We had 300 units. Now we're going to have an additional 200. We're going to have them connected, 200 units connected with our SOS teams upstate. And then we're going to continue to grow it. And even to the point where we aren't doing housing first is really great because it means that we have the apartment, we buy it, we keep it ready. So it's there, and we pay up for a while in advance, and then when somebody's ready to go, they can unlock the door and just walk in. I mean, that's the way you would almost like everything to be, but we might not be able to do that everywhere, but we're getting closer. And I think the other places where we have a certain amount of bureaucracy inhibiting some of what we do, we have to continue to work on that so that some of the housing moves quicker and quicker. But the housing first model is especially important for individuals that we all know if you don't help them kind of at the point that they're ready, it's a little bit like substance use treatment. You have to do it when somebody's ready. You lose them. You just lose them. So this enables us to make that connection with someone and say, yeah, you really want this? Well, I can give it to you on Thursday. You're going to come with me on Thursday? And we can kind of go in and look. And I think that makes a world of difference for some individuals whose lives have been so unstable for so long. Right. So it's a great model, and we want to continue to grow it.
I mean, I would just echo, that is, when I talked about harm reduction, that is exactly what harm reduction is, right? It's meeting people where they are and not having these additional barriers that people have to meet before they can then get to the, whatever point. So, I think for us, that is certainly the model. I think, just sort of thinking for us about recovery housing, for example, it's a little challenging because the model is really quite different in the history, but we're really pushing back because people cannot be removed from their housing because of ongoing substance use. It is a chronic disease. People relapse. That is what is expected. That is the chronic disease model. And so we can't close the door when that happens. In fact, we need to intensify services more, right? And so I think it is, for some, it's a different paradigm. It's a paradigm shift. But, if we close those doors, people will die.
Yeah.
Because the drug supply is so deadly. And so I think it is really pushing in working with people to really sort of change that paradigm. And that's also what I was sort of talking about the willingness to think differently, because we are in a different place now than 5 or 10 or 20 years ago. So it is, some are already there. Some have some ways to go. But we're really, really working through this because that is not, that is an area that the data are there, the science is there to support that, and something we feel very strongly about.
Yeah, I would just add we need to just keep saying it as well because it is evidence-based, and as you said, there are people who are on different parts of this journey toward realizing that this is the right thing to do, and we just need to keep pointing people back to the evidence, and because it's there.
Right. And what about Commissioner Sullivan, you mentioned the 1115 waiver. How is that going to affect supportive housing from your perspective?
I don't know that I'm an expert on the 1115 waiver, but I think some things to keep in mind with the 1115 is that, first of all, the workforce. Really pay attention to that one. Pay attention. The workforce in the 1115 is about over $600 million. And it includes things like pathways, career pathways, as well as loan forgiveness. And career pathways for people like, for social workers, for community workers, for things. So keep an eye out for that. I think that's very important, and I think that is open to us as mental health and housing providers. So keep that in mind. The dollars in there for career pathways, et cetera, I think can really help us with the workforce. The other is that there's a lot of, when you get into social networks, I mean, they're going to be asking all of you to be part of those social networks. And housing, nutritional assistance, people, certain care management services, those kinds of things will be available for the social care networks. And they can be linked to all of you and the housing providers. So I think that those kinds of things are the things that are embedded. When it comes to where it says housing, I'm not entirely clear yet, and we're still talking with DOH about how that might interface with our current housing providers. Certainly, there are going to be medical respite beds. What that will look like hasn't been kind of designed yet, but there will be some work with medical respite beds. And then there will probably be some dollars for at least it mentions things like vouchers and things like that for housing, which might be really good, which wouldn't be the kind of housing we're running, but would be good for some of the clients we see. So I think we're still working with DOH on the specifics about the housing, but keep in mind particularly the workforce and some of the social service connections. I think that it's perfect for our housing providers to be in those networks, utilizing that, getting individuals screened, getting our guys, the eligibility for Tier 2, which is all the services that it has, is a serious mental illness. So all you have to have is the diagnosis of a serious mental illness, and you're eligible. So that's great. And then you can get screened by an agency, and then your social service needs, to the extent that they are available within the context of the waiver, you're now eligible for. So it's going to be really important that we make sure that all our clients get screened and get into that system so that they can get additional assistance on things like nutrition, which is real important for, we know that that's a real issue with our clients, et cetera. So there's a lot in the 1115 waiver.
Right.
Just remember, all our serious mentally eligible for Tier 2, which is the highest level of the social service kinds of connections. And we'll be getting back to you as we understand a little bit more about what the housing might mean.
And I would add, also people with substance use disorders also all qualify for Tier 2 similarly. So I think that's really important. And for us, another important point, not housing itself, but related, is our residential treatment. And for the 1115 waiver, that we have an IMD waiver, so the Institute for Mental Disease. So now that programs that have more than 16 beds can now fully bill Medicaid. So I think that for us is also really important because it, again, allows for more of that sort of stabilization at the end of the continuum for residential treatment.
So I'm dying to ask, as leading a new organization and looking at developing housing to our capital individuals who provide capital, how are you advising developers, nonprofit, for-profit, developers of supportive housing to look at their pipeline and plan? The OMH has a variety of RFPs out there for the CRSROs, but if you're looking at, the typical or the traditional way of developing housing, how would you advise developers to approach it today, if there is a way?
I mean, I guess I would say just sort of at the sort of high level on resources, to the extent that folks are coming to talk to us about 4% and 9% deals, or, we are also trying to, so 4%, 9%, we are limited because we only have so much cap and credits, and we do about 4% deals a year, and we do about 49% deals a year, and that's statewide. So it is, and we are trying to serve the whole state. We're trying to serve the whole industry. So we try to do our best to make sure that people are getting in our pipeline and that we are facilitating that. We understand sort of the importance of that for you all. There is obviously way more need and demand than we can serve. That said, we are trying to find other ways to finance things. So we have, we put out funding for preservation sort of not so long ago as another way to sort of get some more capital into the system. We also are looking to use recycled bonds where we can, if a project can get done without tax-exempt bonds. We're using state credits, and we can use historic credits on conversions. So I think where there are other opportunities for us to get deals done outside of, we also have a small building loan program and a small rent. We have a gazillion programs, but anytime someone can come in with a project that we can do outside of that, we are very happy to sort of get those done quicker and faster. I know they are hard and the economics aren't the same, and certainly the capital commitment is there for us. So we will continue to, as we can stretch our 9s and 4s even farther, we will do that. I would note, it's challenging because construction costs have gone up. So for us, it feels often like our resources are not going as far as they used to because overall total development cost has crept up in construction costs. And there was sort of a spike in COVID, and it doesn't feel like that's come sort of all the way down as a result of sort of supply chain at that time. It doesn't feel like the pricing came all the way back down. So we are often just sort of fighting against escalating costs, eating into sort of the overall amount of funding that we have. But we are trying to work really hard to get every deal, through our system and awarded and closed as quickly as we can. I don't have any magic capital or anything.
I was hoping this would be the moment that I'd have the key, and then would be the infamous panel for today. but no, I understand. I guess in general, resources are limited, and I think what we're experiencing is a lot of conversation goes a long way, right? To be creative in the world that we are in today. Which leads me to one question around workforce. Wages are not necessarily keeping up with inflation. There's been a big push on the state side for COLAs, as we saw in the governor's budget. But your thoughts on how your agencies are approaching this disparity in some ways, right? Depending on contracts, depending on funding sources, who may get an extra dollar in their paycheck and who may not. So as providers out there, is there any advice that you can provide us or guidance as we, kind of work through these different challenges?
Just say keep advocating, because it is certainly a challenge, in particular where there are some certain funding streams that are able to address the COLA and others are not, and they're often people who are working side by side, and makes it even more challenging for all of you to do the jobs that you do. Again, a lot of gratitude to Governor Hochul for supporting a wide range of COLAs, but in terms of expanding that, I would just keep advocating.
Yeah, I think, it's, we've been underfunded, the workforce has been underfunded for a long time, so pulling the workforce up to the level that I know all of you would want is huge. I do think we've had successive COLAs in these years. For the first 3 years, we've had successive COLAs. We have been strained by not having years of COLAs before that, and I think that put us behind. I do think loan forgiveness, as I said before, is important. The other thing is we're developing with our partners in the Department of Labor something called apprenticeships. We haven't got it kind of all formulated yet, but it would basically, I think, be something that could maybe be very applicable to housing, where individuals come in to learn a skill. Not necessarily, don't necessarily go for a license like a social worker, et cetera, but a mental health apprenticeship workers, where you get paid while you learn. And we're working that out with the Department of Labor to see, it's a kind of, plumbers and other kind of tradesmen do this all the time. We haven't really been doing it in the healthcare field, so we're talking with the Department of Labor about that. And we are also developing a mental health, I don't know if we have the title for it yet, something like a mental health associate or mental health support associate which we'll be working on getting the curriculum for, so people can get trained, and it could be an entry-level position, so individuals could come in from maybe high school or from maybe just a associate's degree, or maybe even right after a degree but not yet going for a license, and have the opportunity to get this credential. And we're working on getting that credential payable if we can pull it off under Medicaid, so it can be a credential that we could use in our clinic systems, and also a credential that could maybe help with the workforce pulling the workforce in with a lot of training into housing. Because, I mean, I know you guys do a lot of training. We would like to partner with you to do more, but that's something that can, I think, sometimes entice people to come to work for us because we offer them some special training that they can use then in different places and different times. So we're looking at that as well and working with the universities. We've had success with a small little program with social work across the state where basically we give a stipend of, I think it's only like a couple, $1,500 or something for people to learn some evidence-based practices, but they get an experience in one of our clinics, or they get experience in the area, and then some of them stay with us and decide that this is the kind of work they'd want to do. So I think it's a multifactorial thing. I mean, certainly pay is critical, but there are many other things I think that we have to do to really kind of inspire people to be interested in working with us. And then we have to build some career ladders too. So with that group that I was talking about, the apprenticeship and the, we want to build in a career ladder so people can move up too. So it's not just an entry-level position that you stay in indefinitely. So we're working on those kinds of things. It'll take a little time, but I think hopefully they will also help entice people into the workforce.
Great.
I just want to reiterate, we're so far behind in the workforce. This is not new. This is really a reflection of many, many years that got worse with COVID. And I think, I hear it at every single meeting about workforce. We're not going to be able to fix the problem overnight because it has been going on for years, but I think we are really trying to do as much as we can and from many different perspectives. And so I think, the 3 years of the COLA, we had the healthcare workforce bonuses. I mean, that was $50 million for us at OASAS. We have a bunch of scholarships that are out there for CASACs for people to get their degree in a bachelor's degree in addiction. We're working on loan repayment as well. We're working on paid internships as well. I mean, we're really trying to think about anything and everything that we can do to both support the existing workforce and to bring in the pipeline as well, new fellowship programs. But I do agree with what Commissioner Sullivan said. I mean, money matters, obviously, but it's not just money that we hear, right? That people are exhausted and they're traumatized, and so really trying to think how we can additionally support the workforce, career development, Leadership Institute we have. So I think, we're really trying to approach it from many different perspectives in terms of the existing workforce, bringing in the new workforce, supporting the workforce with dollars, supporting the workforce in other ways around, wellness and career development, all of those different perspectives. And we have a lot of catching up to do, just to be frank.
I want to leave enough time for questions. So we have some mics here in the middle. Ooh, look at that.
Oh, whoa.
This is a popular group.
We need a magic cabinet.
Welcome, yes.
Hi,
You're up.
I'm Paul Freitag from the West Side Federation for Senior and Supportive Housing. Actually, I just have a comment that I want to make about what you just talked about. We're very interested in these sort of scholarship, career development, career ladder, internship, all that kind of stuff. But what we actually find is that all the different opportunities that are out there are kind of overwhelming for our staff, and they really can't figure out how to navigate through them. And so I almost feel like what you need to add to all these resources is almost like a counseling service or something that can really help people navigate through the different options. Because we have one staff person who's sort of helping with staff development, but they really can't be an expert on these new programs that are rapidly evolving. And I think that would really, really help with pickup if you could actually provide some kind of counseling along those lines.
Yeah, that's a great suggestion.
Thank you, Paul.
Hi, good afternoon. Thank you for the panel. I have so many questions that I'll have to save for later, but I did want to address Dr. Cunningham in terms of, one thing I do want to say is what I see. First, I should say my name is Raji Idiathmagla. I'm a senior policy social worker at New York County Defender Services. I was in community mental health. I'm an LCSW. I still see patients in a community setting, and I work with about 300 clients in my office before transitioning to the policy role. So been there on the street, knocking everywhere. So what I do want to say is what I've seen everywhere is fragmentation across everything, everywhere, within the office and across, and the way that's impacting staff, especially case management staff, social workers, and others. is in terms of moral injury and not feeling supported and overwhelmed. So if that can be woven into that. My question, though, has to do with the impact of lack of or minimal use of harm reduction in the court system, because we have people, I'm serving people who cycle in and out of the various systems that have been touched on. And they are very prone to death by overdose. I have gotten clients who've been found unresponsive and died at Rikers. And when they leave, methadone maintenance is a huge issue. The other issue that's ongoing is that when someone gets an opportunity for treatment in a treatment court, they're often asked to be abstinent. They have to do toxicology tests on a weekly basis from the very beginning. And the other part of it is, if someone's getting off of heroin addiction for decades, they want them to be clean of everything, including THC. And it's you can't pull the rug from someone's feet and not provide the necessary supports and structures and services. We all know change is a process. My invitation to you is, how can you get involved with the courts to make this possible? Because it all seems backwards. And advocating case by case, individual by individual, is absolutely exhausting. So I wonder if how can we partner is my question.
Thank you for your question, and this is a really big area that we are focusing on. So let me just say, we know that people who are involved in the criminal justice system are among the highest risk for overdose death. We know that. We now have in our division of criminal justice, we went from a half-time person to 4 full-time people. So really increase the staffing and resources. And in fact, we have a full-time person to work just with the courts in the state. So, we're not in control of the courts, obviously, right? Our authority is under the treatment, but we certainly work closely with our state agencies that work with the courts, that work with jails, and that work with prisons. We, talk about what medication treatment is. We talk about what harm reduction is. We're there to provide resources. And, one thing I'm very proud of is that we are in every single jail and prison in the state of New York, 58 jails, 44 prisons, offering every form of medication treatment to people with every substance use disorder. We are the second state in the country doing that, and the first state in the country that is doing that is Rhode Island, and they have 1 jail and 1 prison. So that will save lives, and that's a heavy, heavy lift, as you can imagine. And again, working with people in criminal justice system, there's a range of, we've had sheriffs say it's all about harm reduction. I nearly fell off my seat, right? But then we also have sheriffs that want nothing to do with medication, even though it's required by law. So we're really working with all of them and trying to move them in the direction of harm reduction and seeing addiction as a chronic disease and, requiring, appropriate treatment. So we're definitely there. We're doing the work, we're partnering, and, we're pushing. But, as you said, change does take time, but we are absolutely there working with our partners across the state.
Thank you.
Thank you. Can we go back here?
Good afternoon. My name is Julie Clegg, and I'm from Mohawk Opportunities. I'm the CFO, and I have a couple of financial questions. But first, I wanted to thank you very much for the COLA. I think it's been a great few years. Unfortunately, with the targeted COLA, though, I just want to point out, if you haven't heard it already, for those of us who made sure we did the right thing before this year and brought all of our lowest 8 wage earners up, we can't bring them up anymore without really being ridiculous. We're very competitive now. And when you tell us that we have to do specific things with money, it really just blows it for us, because up until now, we're doing the right thing, and we got our hands slapped because now we can only use it on this. We're trying to work on bonuses. I know the ways to make tricks to make this happen, but it really is disruptive. We need the money to pay what we need to pay, and there's things much farther beyond the salaries that we need to be paying. Insurance, it all, utilities, whatnot. But I have 2 questions, because we like money that is not tied to specific things. And I understand that we're supposed to be seeing a fair market value adjustment that I have heard nothing about. And I also understand that we are supposed to be getting, what was the second one? I go to council. Sorry. Old woman, you know. The fair market value, the billing. We're still billing. In supported housing, we're getting some money for doing that. I think it was $600 a bed. We continue to bill, and we know that last time I heard Emil speak, we were getting nowhere. It's a lot of work for us. Not sure why we continue to do it. It's the second year of doing it, and wondering what's happening with that.
Thanks. So who wants to tackle those? FMR?
Julie?
Lovely.
When do we have it? Yeah, sorry about the delay on the getting the money for the Medicaid. It's being worked out. It should be, I'm sure you've heard this before, but it should be soon, and we appreciate what you're saying, and we will get it out there. But you're absolutely right. It's been delayed, but we're working on the rates. We're working on how to get you the money, and we truly appreciate everybody who's been doing this, because it does make a difference in terms of being able to support housing. So we'll be working on it, and we'll be getting back to you. But I'm sorry that that's late. I'm sorry.
It's okay, Doctor. Is that the fair market value adjustments you're talking about, or is this the
No,
billing piece?
Yes, the fair market's coming. The RTS funding is already out there. They're already getting it. We as the state have not.
Just
Can't
stand up
hurt
and
her.
say,
Can't hear her.
Julie, just stand. Julie's the expert on this. Julie's the expert.
Hi, Julie.
The fair market rate increases are coming. We're figuring those out right now. We should be announcing those soon. The RTS funding, which is the Medicaid billing, you're already getting that money. We as a state are preparing claims for the first and second quarter. We have like 2 years to bill. So we're preparing claims for the first and second quarter, but you're already getting that money.
Mm-hmm.
And our initial analysis is that what we've already put out is pretty close to in line with what we're going to be billing for, though we maintain our commitment that if we experience more revenue than expected, that we will put that back in.
Thanks, Julie.
Thank you. One more back there, then we'll come back up front.
Hi, I'm Mark Hurwitz. I'm with the Health and Housing Consortium, and we invite you and everyone in this room to have your organizations join us in bringing together the healthcare and the housing sectors so that we can address these problems of homelessness and mental health and overdose. And thank you, Blanca, for asking the question about the 1115 waiver. And I'd just like to ask a follow-up, because I believe out of the $6 billion that's going to be spent under this waiver over the next 3 years, that about 3.8 billion of it is going into the social care networks, and that pre-housing, housing search, pre-housing support, and support to stay in housing, according to the waiver application at CMS, are eligible. And just wanted to know, what are your agency's role going to be in helping the DOH to define what is billable? A lot of the people in this room are probably disappointed with how the DSRIP money was spent or wasn't spent, and there is a huge opportunity. It's a huge amount of money to use that waiver funding for things like housing first, like preventing homelessness of the hardest to serve people who need to maintain their housing. So any thoughts you have about how your agencies could advocate, we'd be very interested in hearing.
Well, for example, we're working very closely with DOH. They haven't kind of outlined this is a lot of money to move in 3 years. Even less than 3 years now as the clock is ticking. So there are different pieces of the waiver that they have concentrated on getting clearer. One of the big things was just how to establish social care networks, getting the RFPs out for these social care networks. Some of these other finer details are still being worked on, but we're working with them. So any ideas or anything anyone has, I mean, we'd be glad to hear as well. Please let us know. Chris Smith, who's here in the front, is stand up, Chris, say hi. Chris Smith, who I think had the president before, is really working very closely with DOH on this. So you can give us your ideas and suggestions, but some of it just hasn't been worked out yet. But we are working very closely with DOH.
Thank you.
As is OASAS, I would just say.
Yeah. When I say we, it's the collective we. It's all the agencies working together. Absolutely.
Back up front.
Thank you. My name is Alan Rodriguez-Penny. I'm a public psychiatrist. I do a lot of street psychiatry. I work in shelters. And as a disclosure, I'm a board member on OnPoint NYC. And OnPoint, for those who don't know it, it's a holistic program, harm reduction program, that in addition to the services, they include overdose prevention centers. So a place where people can use under supervision, and if there's any signs of overdose, they can intervene. So far they've intervened hundreds, 600 plus times just in like 1 year. I'm disappointed in terms of New York State's approach to this. I understand the times I've asked before, it's too complex or too political. And I would challenge that in regards to like, cannabis is illegal on the federal level and legal on a lot of state levels. So in terms of thinking about innovative ways, evidence-based ways to address the overdose crisis, I would like to ask for that. Thank you.
So this issue has come up multiple times, and really this is a legal issue. So it's a legal issue in terms of state law and federal law, in terms of, overdose prevention centers not being permissible. I do want to point out, though, and I appreciate your comment, this is sort of where I started from, is we are doing everything from a harm reduction standpoint that is legally permissible. There are states out there that are treating fentanyl test strips as, illegal paraphernalia. That's not happening in New York State. So I think, again, as a governor, she's had a nephew die of an overdose. She is very committed to really a harm reduction approach. We've created a new division of harm reduction at OASAS. We've put out nearly 16 million fentanyl and xylazine test strips, and then over 100,000 naloxone kits. Free. People can go on our website. It takes literally 15 seconds to put in your information and order it, and we'll ship it to you. So, we are trying to think about innovative ways within the context of the law to be able to really take a harm reduction approach to save lives.
Thank you.
Great. Leora?
Oh, hi. Thanks, Blanca. My name is Leora Jontef, and I'm the Assistant Vice President for Housing at New York City Health and Hospitals. I oversee our Housing for Health program. I think it's really wonderful to have the low barrier SOS beds, but how can we make LIHTC more low barrier? That is the bulk of supportive housing in our city. We are trying to house our most vulnerable and frail patients into supportive housing, yet the rent-a process is egregious, and people get sicker while waiting. How can the state use its influence to use Medicaid as presumed eligibility in LIHTC? How can we collectively influence Treasury to align with HUD's self-certification of income? I just feel like it's a missed opportunity.
Yeah, I would say on the marketing and lease-up, we agree, and there should not be as many, we shouldn't be asking, I think other people have said this better than me, but we shouldn't be asking people multiple times how poor they are, so they can just give us lots of paperwork that they may or may not even have to show that. I think we have to work within the confines of the LIHTC program, but always happy, I think, to keep reducing barriers there, and appreciate the comment that people, and it takes a long time, nobody is well served when there's affordable apartments sitting vacant. I would admit that I can't speak to the Medicaid side of things, but I'm always happy to get better educated by my colleagues here and in the audience about how we can push forward on that, and would say on that advocacy, it's the reason sort of why there was New York 1, 2, 3. It's the reason why there's ESHI, people asking for us all to be accountable and putting targets and holding us to those is important. And I think this is probably another one where, working towards changes in Medicaid, which I think already does happen, probably more so from these folks than at HCR parochially, is certainly something we need to put back in focus and see if we can make some changes there.
Yeah, I would just say that family of one makes $18,000 to qualify for Medicaid. That's what I was asking RuthAnne, because I just think that they presume would make the 50% AMI. So if there's just a way for all of us, I can't influence, but I just try to use this as a forum to sort of be how can we use Medicaid for LIHTC? That just feels like an easy win for everyone waiting to be housed.
Yeah, there's definitely more education that needs to be done on the investor side too. I think that's a piece of it that I guess I can say now that I'm on this side. So talk to them.
Thanks.
Up here.
Hi, my name's Amanda. I'm a housing outreach specialist. I'm pretty new to this whole arena, but my gist so far that I've kind of sensed is that there's a lot on sort of the bigger picture things, like number of shelters, number of safe havens, things like that. But it seems like, and this is probably an issue with a lot of social justice things, but that there's a lot of oversight of the little details. So like a lot of bureaucratic nuances that are making the housing that we do have inefficient. Like, someone calls from a rehab center, I'm going to be discharged tomorrow. Can I get a safe haven placement? And we have to say no because you have to spend a night on the street first, which is absurd. Or like I have a client who doesn't have chronicity, so she won't apply. She won't be eligible for as many places. And things like that, or getting birth certificates, you need an ID to get this ID, and to get that ID, they have to have an EB, all this stuff that's just like little details. What is the activity happening on addressing that from a policy standpoint? And maybe what is the pipeline for people who are on the ground, like my organization, to get a kind of more direct line to the policymakers to be like, hey, we need to change these policies because they're making everything way harder, kind of thing.
It's always good to hear from someone who hasn't been doing this for a very long time to point out some of the things that we need to pay attention to. So thank you. We'd be happy to talk with you.
Yeah, I agree, and there are lots of things, like the things that you mentioned, that are obstacles, and I think many of them were put in place because people felt, well, this will help with that, and this will be a safeguard against that, but they end up being obstacles to people getting what they need quickly. So you're absolutely right. I mean, we do try to get rid of some of these, but send us your list. And believe me, we get the lists a lot, and we'll see what we can do, because it is critical. I mean, there's no reason in some ways that it should be so difficult. And when you get rid of those things, when you kind of push them aside, people get served better and quicker, and they get what they need. So please, forward us the things that you mentioned, and we'll definitely continue to fight for those. Some of those we have been pushing for already, but we'll see what we can do to modify it, because you're absolutely right.
Thank you. And up here?
Thank you. So I have a little bit of like a long question. My name is Tanima Hassan. I'm a housing advocate from Safe Horizon Street Work. I work at a youth drop-in center serving youth under the age of 25. Currently, as of right now, as you may all know, there's been an influx of people coming into our country, especially our beautiful city, looking for shelter, escaping some really horrible things, and some of the stories that you'll hear, they'll break your heart. And one of the things that I do as a housing advocate is I support supportive housing applications. And one of the things that we run into over and over again with trying to get these young people housed is that a lot of these shelter systems are not giving us residency letters or having a system of tracking people to be able to say that there's a centralized way of making sure where have they been. And we have the care system through DHS where we can submit a request and we can find out where somebody's been. But for these people, we've gone to OTI and we've received an Excel spreadsheet that has like 2 lines on it, and it's like, you guys at the government, you should know that that's not going to work on a CAP system. So my question to you guys is that, do you guys think housing is harm reduction? Is there a way that's going to be developed to keep track of all of these people, not just young people, but everyone, so that going forward, when we do submit these applications, we can get residency letters, we can get a way of where these people have been, and just kind of be able to help them?
Thank you for raising that issue. It's not one that I personally have heard before, but I suspect some folks in our agency have. As you know, the system itself had to expand significantly, very quickly, in order to provide places for people to stay. And as a result, I could certainly see that in all of that very quick acting and bringing in new partners that had never before operated in the space, that certainly could create a lot of gaps. So again, I'd be happy to follow up with you, and certainly we can have conversations with folks in New York City to address that issue. Thank you.
All right, thank you so much.
And up here.
Hello, I'm Dan Kent, CEO of Lantern Organization. Could you speak to any regulatory changes or state initiatives that are aimed towards increasing access to medication for opioid use disorder and alcohol use disorder? And also, how can you envision the supportive housing industry and operators being more involved in helping to ensure our clients access these life-saving medications? Thanks.
Thank you for that question. I mean, honestly, I could talk about this for hours. So this is something we are very, very passionate about. I mean, this is, evidence-based. Clearly, medications reduce overdose death by 50%. There's nothing else we really do in medicine that has those kind of results. Like all the blood pressure medication and cholesterol medication that everybody's taking does like this much for reducing death compared to methadone and buprenorphine, for example. So there are huge changes in regulations around methadone at the federal level that happened with COVID, right? Because we changed on the dime and there was a lot more access and people were able to take home their methadone doses. And so those rules have now been made permanent. So we are thrilled about that, and we are really working with our programs to think about how we can leverage those changes, so that people have more access and are more likely to be retained in services. Again, I'm going to say, these are changes really, I would say the first substantial set of changes in the methadone treatment system for 50 years. So there's a lot of people out there who are used to providing services in a very specific way, and this is a really big change for them. Again, some people, some of the programs are super excited and are already, making the change, and others are weary and cautious and concerned, and so we're really working with them to try and move them along. So some of the things that we're doing include mobile units, so we have 11 units that we're funding to go. So those now, if you don't have a brick and mortar opioid treatment program, you can, take these units and we'll go to where people are. We're going to homeless shelters. We're going to jails. We're going to parks. Right? So these are just started coming online, and more will be coming online across the state. Just to give you an idea, there's 11 of them that we're funding. There's 44 in the country. No. Right. So we're really pushing the envelope here. We're using telehealth on those, which are now possible. Right. We're doing this in front of jails and prisons. Is the other earlier comment around the criminal justice system and courts. Thinking about putting a unit in front of a court. We're expanding, integrating opioid treatment programs into our outpatient programs. We've invested, I want to say about $30 million or something in there, and we're going to have 45 additional programs with integrated opioid treatment programs and outpatient programs. Again, just to give you an idea, 45 additional ones. We already have over 100 in this state. There are states that have 0 and 2 and 4 and 6 opioid treatment programs. We're going to have 150, right? So we are really, even though we're sort of at the cusp, we're just pushing and pushing and pushing because this is life-saving treatment. We know it works, and we have to get it to where people need it. And so we're working with our programs. We're literally leveraging every regulatory change to really expand access. So stay tuned. It's happening right now, but a lot are coming online now and over the next year to really make sure that people have access to the gold standard treatment.
Great. We have time for one last question. I think we have a repeat up here.
Hello, Alan Rodriguez-Penny again. I know the drug supply and composition changes a lot, and there's some places where they're doing drug testing. And like every week or so, I get an email where there's like an increased prevalence of influenza or a measles outbreak. And I was wondering if there's been any thought or initiative about providing, like in addition to the fentanyl and xylazine test strips, any information about what the drug supply is like at any given point in time so we could better educate and inform our participants about what's out there, what they're using, how they might want to consider using it.
Yes. Yes. So there are drug checking programs that are happening right now. There's a range of them so that we can pick up, not just the fentanyl test strips and xylazine test strips, but other substances. And as you said, it's fentanyl and xylazine today. What is it going to be tomorrow? I have no idea, or next week, but it's going to be something, right? And so following the data and the science is critical. And so having these drug checking programs is really important, and that is being supported right now. I think the technology, it still has some ways to go because it's very cumbersome in terms of the programs. But I think, this is an area where there's a lot of development happening. And so, as that continues to happen, we want to bring these services out into communities to do more of these drug checking. So, this is in line with what we're doing, that people, if they're going to use a substance, to know what's in that substance so that they can take the appropriate, they can change their behaviors. They can either not use, or they can use half of what they would use, or use more slowly, or have somebody nearby, or naloxone nearby. But giving people tools that can reduce the harm is definitely part of what we're doing and what we're supporting.
Thanks. And then is there a way to access that data, or at least inform providers so then we could pass along that information?
I want to say either the New York City Department of Health or the State Department of Health has published some of this. I want to say that there's a dashboard. If you give me your information, we can send you the links to that. But there is publicly available information coming from the drug checking programs.
Is it real time?
I don't have all the details of it, but we can certainly share the information with you.
Thank you. Thank you for all your questions. I wanted to take some time to thank our commissioners for taking the day or time out to answer our questions. And thank you for all your great questions and comments. And on to the next, right? Thank you.